Hey, I loved that talk, Dave. Don't overtreat. That's really awesome. All right, I'm delighted to introduce one of my favorite people at the Cleveland Clinic, Dr. Holly Pederson. Dr. Pederson is the former director of the Cleveland Clinic Medical Breast Program and a professor of medicine at the Cleveland Clinic Lerner College of Medicine. Always an interesting, exciting conversation. Dr. Pederson.
Thank you so much. It's just wonderful to be here, and it's so exciting to see all of you. And I was an hour off on time zones yesterday, and so I got to the party early, and it just seemed so empty. And now it doesn't seem empty anymore. You know, it's hard to be without Karis. But are you pulling it up? Okay. You know, you may have a P10 mutation. You may have had a history of breast cancer with or without a P10 mutation. You may know a woman who's between the ages of 40 and 90. You know, this talk is really aimed at, which one, this one? Okay. Aimed at information that's useful for everyone about breast cancer screening and breast density. There's a lot of confusion. You know, there's always a lot of confusion around breast cancer screening. Just when you think that you have got the guidelines, you know, straight in your head, they change them or they're conflicting and no one quite knows what to do. I do have several companies that I consult for that are not relevant to this presentation. So we'll review current average risk screening guidelines. We'll talk about when to start, when to stop, how often to go, understand the risk factors for breast cancer, and more importantly, what we don't know, and identify those who are mammographically dense and may benefit from supplemental imaging, appreciating the differences between the types of supplemental tests. Has anyone had a mammogram since 9/11 of this year? No, you have. There's new language in the letters that are going out, and that's part of a new FDA law that we'll talk more about. And it's really very confusing for people. And so I think it's important to know. What?
It's working.
Okay, great. So we're going to talk about who, what, and when in terms of average risk screening, and then of course go into P10 and how that plays into screening. So this is what the breakdown of breast cancers that are diagnosed look like. The hereditary high risk group is quite small. About 10 to 15% of all breast cancers are related to an inherited abnormality. There's another 15 to 25% of patients who develop breast cancer in the setting of familial clustering. But you can see that the majority of people who develop breast cancer really don't have any identifiable risk factors. So we cannot, at the current time, identify low-risk people. We can call women higher risk if we know that they have risk factors, but we can't identify lower risk women who may not want to be so vigilant at the present time. And it's also important to look at the types of cancers that develop in various races and ethnicities. You can see that breast cancer is the most common in white women, but the mortality rate in Black women is much higher than in any other group. And in fact, the most recent numbers are that the mortality in Black women is about 42% higher than in white women. And Black women in particular are prone to early onset disease and early onset triple negative type breast cancer, estrogen receptor negative, progesterone negative, and HER2 negative, which can be one of the most aggressive types. And so when you're screening, you have to think about young Black women who may be developing breast cancer early, and actually young Hispanic women as well. You know, the USPSTF in 2009 and then again in 2016 set forth recommendations advising screening mammography starting at 50 and ending at 74 every other year. and there are different regimens throughout the world that are being used. But you can see that 19% of all cancers occur under the age of 50. And that's even higher in Black women and Hispanic women. And so this year, the USPSTF lowered the age at recommendation to 40, but they are still recommending every other year. And I'll talk about why I don't agree with that. But it's interesting. You wonder, like, why did they pick 40? Why did they pick 50? And why are we picking 30 for P10? So the average risk of an average woman to get breast cancer before the age of 50 is 2%. By age 40, it's 1%. But in patients who carry BRCA mutations or P10 mutations, that 1 to 2% risk level occurs at the age of 30. And so that's why, that's why the screening is initiated earlier in high risk groups. And we'll talk about why that's important. This is just a breakdown of breast cancer genetics. We're learning more and more about the different levels of genetics. The highly penetrant genes are very rare, like P10. There are other moderately penetrant genes that can be linked with hereditary breast cancer. And when you have genetic testing, it's these two groups that you're being tested for. But we're learning much more about single nucleotide polymorphisms, which are common genetic changes. Individually, they confer very small levels of risk, but in aggregate, they may be important, and they may also substratify risk in patients with highly penetrant gene mutations. So we're going to be seeing the availability of polygenic risk scores, which are like a weighted combination of these SNP risks, which may help patients with P10 in clinical decision making. Ultimately, that is one of our hopes. There are guidelines for genetic testing that are put out by the National Comprehensive Cancer Institute, or NCCN, and those are important for people to be identified as hereditary high-risk carriers. But you have all taught your providers, your physicians, and others about P10 and how to identify P10, and they all thank you, as you go along, because we can identify patients with BRCA a lot easier than with P10. So what kind of testing are we talking about? There's digital mammography. That's the old two-dimensional mammography. And then there's digital breast tomosynthesis, which is the three-dimensional mammography. And, why is there so much confusion around breast screening? I'm really not sure. Of course, it has nothing to do with money or anything like that. But the benefits of breast screening include earlier detection, lower stage, increased survival, less invasive surgery, and less invasive treatments. The potential harms, however, of screening include the radiation, and we'll talk about that, stress from recalls, false positive biopsies, overdiagnosis, and decreased sensitivity in dense tissue. Now, when we talk about, I was interesting to hear Dr. McFarland talk about not over biopsying things that are most likely benign. And we run into that with breast cancer all the time in terms of over biopsying. Can you open this for me, please? And so we're going to talk about why the screening guidelines are the way they are and why I agree with the screening guidelines the way that they're written. So when do we start and when do we stop? The USPSTF, they commissioned this modeling agency, CISNET, to project different scenarios for mortality reduction with screening mammography. Did he take that out of the, oh, there it is. There it is. You're going to get, oh, I don't need a glass. So they looked at what they used to do, 50 to 74 every other year. They looked at what they're now recommending, 40 to 74 every other year. They looked at 40 to 74 every year, and they looked at 40 to 79 every year. And they looked at the mortality reduction not only in white women, but they looked separately in Black women in this analysis. And we'll talk more about the decisions that they made and why they made them and what the American College of Radiology recommends. But for average risk women, most of the guidelines in this country recommend annual screening tomosynthesis beginning at age 40 and continuing as long as the patient is healthy. And so those are the guidelines that we recommend at Cleveland Clinic. And it's that gives you the most reduction in mortality from screening, which is really the whole point. So these are the 4 groups that they looked at. And what they found was that false positive screening results were actually lowest for annual screening from ages 40 to 79, and benign biopsies per examination were lowest in that group as well. If you look at the mortality reduction chart, you can see that overall, screening mammograms reduce mortality from breast cancer by about 30%, 24% in Black women, if you do the every other year from 40 to 74. But if you do annual screening from 40 to 79, these numbers go up to 42% and 40% in Black women. And the American College of Radiology looked at this data in addition to a literature review revealing that the Breast Cancer Surveillance Consortium demonstrated, which would be obvious, greater risk of later stage disease and larger tumors in women who are screened every other year rather than every year. And the American College of Radiology said, you know, of course, we're going to recommend annual screening from 40 to 79. USPSTF decided to accept this, which is, it's a judgment call. It's really a judgment call in terms of the choices that we're making. And so keep that in mind. Advocate for yourself. Think about, you know, what your goals and desires are when it comes to the best tests that you can have, because we're making these decisions with you, and you need to know some of the data as well. When to stop? You know, is it really okay to stop screening at 74 or even 79? Most of the major organizations recommend that we do continue to screen women after the age of 70. And in fact, over 30% of breast cancers occur in women over the age of 70. And so it's, you know, it's kind of ageist to exclude them. The real issue is that women over 75 have not been included in clinical trials, so there's insufficient data in that group. And this is a table that I got from a Social Security website in planning your retirement. And, you know, if you live to age 70, you're likely to live to age 87. And if you live to 80, you're likely to live to 90. If you, you know, and et cetera. So the older you get, the older you get. And, you know, it's actually not a great idea to stop screening, I don't think, at 70. And in fact, some major radiology groups have recommended that we continue to 90 in healthy women. Mammography is more sensitive in that group. There's lower recall rates and lower false positive rates. And so that's an important thing to keep in mind. So start at 40, continue as long as you're healthy. even up to 90. I wanted to mention pregnancy-associated breast cancer because that may become relevant in some of your families in terms of the changes that the breast goes through during pregnancy. And this is a time when there is a bump in risk in terms of having a genetic predisposition and then becoming pregnant. It also affects your screening. And I wanted to talk about the changes that occur that may interfere with screening and what to do in that situation, because that may come up. These tumors tend to be more biologically aggressive, more difficult to diagnose, more difficult to discern from the surrounding tissue, both on physical exam and on imaging. And what a lot of women don't know is that you can get mammograms, even screening mammograms, during pregnancy. The best time is usually at the beginning of the second trimester, because if we're going to intervene, that's when we want to intervene. MRI is contraindicated during pregnancy because the gadolinium crosses the placenta and may be teratogenic. But during lactation, both mammograms and MRI are okay. They're not as sensitive because they're limited by the background enhancement. And you should pump or feed right before you have your mammogram. But a lot of people don't know that you can have screening mammograms during pregnancy. And the radiation dose is 1/600th what it would take to potentially harm a fetus. Certainly, if anything comes up during a pregnancy, it should be evaluated thoroughly. So we'll talk more about high-risk screening. It's interesting this year because our accrediting body, the NAPBC, who evaluates breast centers for centers of excellence, this year is going to require that risk assessment be performed at the time of screening mammography. So you're going to be seeing on your mammogram reports estimates of your lifetime risk. We all know in this room that 40 is not the appropriate age to start identifying high-risk women, but at least it's something. It's a step in the right direction in terms of identifying patients. And the reason, is because MRI, full sequence contrast enhanced breast MRI, is the most sensitive way to catch breast cancers early. And patients with P10 definitely fall into this group where MRI is recommended annually starting at the age of 30. There are other groups for which high-risk screening is recommended. These are the NCCN guidelines for the management of P10. And I really wanted to kind of go over this because breast awareness starting at 18. We've already had 2 speakers talk about breast self-exam, and I'll go over that in some detail. You're absolutely right. Many women find their own breast cancers, and to advise against self-exam is just absurd. Many organizations now are arguing against having the physician examine your breasts as well, the clinical breast exam, and we strongly feel that that's necessary. Beginning at age 25, every 6 to 12 months. So when those patients transition from the pediatric programs to the adult programs, I will typically recommend an annual clinical exam between the ages of 18 and 25, and then clinical exams every 6 months. It's not recommended that patients have imaging in their 20s, although I wouldn't have an issue with getting a baseline MRI at age 25 if you can get it put through. But the problem with screening in P10 in your 20s is that the risk of breast cancer is less than 2%. Okay, it's between, it's probably much less than 2% when you're in the 20 to 25 age group. And there are a lot of false positive biopsies being done on the basis of screening ultrasounds. And then the ultrasound will lead to a biopsy, which will lead to an MRI, which will lead to a 6-month follow-up MRI following the negative biopsy, which leads to another finding. And women with P10 are going to have benign breast findings, fibrocystic changes, fibroadenomas, a lot of other things that may show up. And I often will see a young woman, who's 26 and has had 8 negative biopsies and is beside herself. And, she's thinking about bilateral mastectomy when she's not even at a risk level that we would begin screening at. So be real careful about screening in your 20s. It can be fraught with false positives. We don't do mammograms before the age of 30 because in the BRCA population, we've found that there may be a slight increased risk of breast cancer. They looked at women who had received not only mammograms but chest x-rays, and there was a slight increased risk. And so for that reason, we don't do them under the age of 30. So at 30 for P10, we alternate the digital breast tomosynthesis, or the 3D mammogram, with the MRI. And that goes on up to 75, but then even after 75 if the person is healthy. We also discussed the option of risk-reducing mastectomy in individuals with pathogenic variants. In patients with clinical Cowden syndrome, I think it should really be based more on family history, but with the pathogenic variants, the rate of the development of breast cancer is at least 60%, maybe as high as 85%. And it's certainly something that should be discussed and considered. And many patients are very satisfied with the cosmetic result. They've come a long way with that. So you've heard about the other cancers that women are at risk for, but I just wanted to emphasize that these screening guidelines really do make sense, and it sometimes it feels like more is better, and that earlier is better, but it actually can cause a lot of problems for young women who may not be able to process a lot of these false positives and the course that it leads to. So these are the NCCN guidelines for high-risk patients. The annual TOMO, 10 years earlier than the first affected family member, but not before age 30. And MRI, 10 years earlier, but not before age 25. The risk is just very low before 25. And insurance often doesn't cover it under the age of 25. And Dr. T, I'm going to call him now. Maybe we'll get him a necklace, like Mr. T. Dr. T pointed out that the average age of breast cancer diagnosis is between 38 and 46. And so that's similar to BRCA. And so earlier screening before the age of 30 doesn't make sense. Unless you have a family member that developed breast cancer under the age of 40, then you would start, 10 years earlier than that affected family member. That would be the only time that you would do it. So that's just a reminder to talk about a little bit about breast self-exam. The breast is bordered by the clavicle on the top, the inframammary fold, and then the sternal border and the anterior axillary line. Basically, it's kind of like Nike, just do it. There's no right or wrong way to do a breast exam. You want to examine the entire area of the breast and know where those areas are, and examine the lymph nodes that may be associated with any problems that develop, both above the clavicle, below the clavicle, and in the axilla. There are also some internal mammary nodes that are under the chest wall that you can't feel, but you want to feel for those lymph nodes as well as any sort of changes in the breast tissue. And the clinical breast exam is recommended every 1 to 3 years in average risk patients from 25 to 40. But with P10, again, I would do it every 6 months starting at age 25. And it's funny because, you know, they've changed the verbiage from breast self-exam to breast self-awareness, you know, and I'm not sure how you can be aware of your breasts without touching them, but, it's, it's sort of a fascinating concept. You're to be familiar with your breasts, and promptly report any changes to your healthcare provider, but they're advising against examining them. But this is what you're going to look for when you do examine them: discrete masses, pain in one location, unusual nipple discharge, which might be bloody or kind of pinkish. It comes out on its own. It's usually from one side and one duct. You want to evaluate for milk when you're not pregnant, and other types of nipple discharge that can be usually benign, which is black, tan, or greenish. You want to look for skin changes, nipple inversion, dimpling of the breast, or scaling or erosion of the nipple. This is an example of a nipple retraction where you can see that something is pulling that nipple in. And that's what we worry about, in terms of cancer development. A lot of people worry about the development of inflammatory breast cancer. And this is a patient with mastitis, and this is a patient with inflammatory breast cancer. The main differences are that this will come on overnight, over the last 2 days, extremely tender, often associated with fever, bright red. And this will come over like 4 to 6 months, not as painful, often ignorable by many women, and often misdiagnosed by many physicians. So you want to use the pads of your 3 middle fingers and go in circular motions covering the entire breast area and pressing down hard enough to get to the chest wall. And these are the different ways that it can be done. I like to go from the outside to the inside and then make sure to press right under the areola and give the nipple a gentle squeeze. But I strongly believe in breast self-exam. So what's going on in the U.S.? And I apologize for people from other countries where this may not apply. But as of September 11th, typo, all mammogram reports sent to patients in the U.S. are now not only required to report your breast density, but to encourage you to speak with your provider about supplemental imaging if you are mammographically dense. But concurrently, the USPSTF, when they made the recommendations for the mammograms every other year from 40 to 74, they also said evidence is insufficient to recommend supplemental imaging at this time. And so patients just don't know what to do, and providers don't know what to do. And we don't know what's going to be covered yet. So this is all just beginning, and we're starting to sort it out. But my recommendations would be, find out if you are dense, find out if you're extremely dense or heterogeneously dense. There's 4 categories of density, and we'll go over that. But if you have extremely dense breast tissue, you want to push hard for supplemental imaging. Dense breast tissue is really a subjective assessment of the amount of fibroglandular tissue, which appears as dark or white on the mammogram, and the amount of fat that appears as black. And so you can see there's these 4 categories of breast density. This breast is almost replaced entirely by fat. And this one, unfortunately, is a little obscured, is extremely dense. And only about 6 to 8% of women are extremely dense, but it really does obscure the detection of small cancers, and also is an independent risk factor for the development of breast cancer. The sensitivity of screening mammography, the ability of the mammogram to detect a cancer obviously goes down as the density goes up. You're much less likely to be able to detect it. So if you look at this little breast cancer here, you can see how hard it is to see in this tissue. These are the extremely dense people, and heterogeneously dense, it's not as bad, but these two categories are considered to be dense. And almost 50% of women fall into these two categories. And so America and other places, we're not going to be able to field the need for supplemental imaging, and you are going to need to advocate for yourselves. More information can be found on densebreastinfo.org. It's a very good site. But I really encourage everybody to be their own advocate. What about supplemental imaging? You know, we've all heard about whole breast ultrasound for the longest time. You know, women kind of who are not at high risk or who don't want to be in the MRI scanner may have whole breast ultrasound as an option for supplemental screening, and it makes them feel better. If you screen 1,000 women with the digital mammography, the 2D, you're going to find about 5 breast cancers per 1,000 women screened. If you add the digital breast tomosynthesis, the 3D, you're going to add an additional 1.5 cancers per 1,000 women screened. And if you add whole breast ultrasound, the most recent numbers are that you are going to have an additional 1.1 cancers per 1,000 women screened. Now, if you take women who are mammographically dense and put them in the 3D mammo machine and it's negative, and then put them in the MRI, there's a 27 per 1,000 additional cancer detection rate. And so the supplemental yield of full sequence contrast enhanced MRI, it's at least 15 and usually is quoted more closer to 25. The 27 is probably on the high end. But it's far more sensitive than any of these other tests. It's always been criticized for its false positive rate, but you can see that the specificity has really improved over time, and there aren't as many false positives as there used to be. And you look at the false positive rate of whole breast ultrasound, the specificity is much lower, meaning that there are many more false positives. And so with P10, you're going to have benign changes, and you may end up with a lot of benign biopsies if you're not careful. So digital breast tomosynthesis is considered supplemental as it adds about 1.5 cancers per 1,000 women screened. Fast MRI is another great option, or abbreviated MRI, which is available in our location. Not we have limited availability at Cleveland Clinic, but at a neighboring hospital, they have a full program. It's $250 out of pocket in our area, but it's similar to full sequence MRI, both in sensitivity and specificity. And a newer thing that's coming is contrast enhanced mammography, where you actually get an IV and iodinated contrast. And it has a decent supplemental yield of 13 to 15 per 1,000 women screened. But if you are going to embark on it with large populations, you're going to have a certain degree of anaphylaxis because of the iodinated contrast. So that's something to keep in mind. So the NCCN recommends for high-risk women, MRI. If you're unable to go through the MRI, either due to implanted metal or claustrophobia or other reasons, it's recommended that you have contrast enhanced mammography as a next step. Whole breast ultrasound isn't even on the list anymore because it's just not as sensitive as we once thought that it would be. So in the future, you know, we're probably going to be looking more at circulating tumor DNA. We're looking at ultra-fast MRIs and possibly non-contrast MRIs, so you don't have to have an IV to accommodate this, this large group of people that are going to be in need of supplemental imaging. And AI is going to change everything. I mean, it's whatever your area of expertise is, whatever you do, AI is coming along, and you know, it's doing things like reading all the mammograms in the morning and putting the ones that are worrisome on the top, so that the radiologist who's fresh and and can get that patient in later in the day sees the bad ones first. I mean, it makes sense. It's not going to replace radiologists, but radiologists who use AI will replace those who don't. So key takeaways: screening mammography remains the gold standard and reduces mortality from breast cancer significantly. Given the masking effect of dense tissue and increased risk of developing breast cancer, supplemental imaging tools are available to augment screening. And these letters that are going to come out are very confusing, and there's no clear recommendations as to what women should do. Efforts to address underutilization of genetic counseling and other risk-reducing interventions, including enhanced surveillance, are important for all women. And for women with P10, breast self-awareness to begin at age 18, I believe annual exams to 25, and then clinical breast exams every 6 months thereafter. I really would try to get a screening MRI at the age of 25 as a baseline, although you're opening a can of worms and may find things that then lead to those unnecessary biopsies. But the formal recommendations are to begin screening mammography and MRI at age 30. Same with survivors who have remaining tissue. And we individualize screening for those over 75. I've included a list of resources for all of the differing guidelines, if you're interested in that. And I too just want to express my sorrow. She was a friend. She was a mentor. She shaped my career. She supported me unconditionally. She was always available to me. She made me laugh. I always look forward to seeing her, and I look forward to seeing her again. So great lady. Thank you. Right. Leave all my stories.
Hey, let's go with some questions. 2 questions. Oh, Dr. T.
Any word on risk in our male patients in terms of breast cancer?
Risk in male patients.
Male patients. So there's no, so the risk of breast cancer in average risk women is 1 in 8 or 12 to 13%. In men, it's less than 1%. In men with BRCA2 mutations, it's up to 7%, and probably BRCA1 and PALB2 have about a 1% estimated lifetime risk. No association with P10 for men, as far as we know. Yeah. Yeah.
Well, you measure the sensitivity and specificity of each and every technique by how many patients you diagnose. But can you flip it? Can you measure it on how many patients you miss? And is there a threshold whereby technique I, Y, Z reach the detection limit? Basically, you are catching them all. There is no way that you miss.
Yeah, I think what you're asking is, our radiologists are actually, when they're reaccredited for their center of excellence, they must be calling back at least 10% of patients, and sometimes up to 15% of patients, in order to make sure that they're catching the cancers. Is that what you're referring to? No.
The fact that it would be very gratifying to know that if I am subjected to tomography and then MRI, fast MRI, I am reassured that if I am not diagnosed, I don't have it. And to which extent AI may add to reach the 100% of accuracy?
Yeah, so the accuracy of these screening modalities varies by age, and the sensitivity of screening mammography in a woman's 30s is about 30%. And it ranges from 60 to 88% ish in women who are of screening age between 40 and 70. But with the addition of MRI, we see varying estimates, but in high risk populations, it's really up to like 95%. You're pretty sure. Yeah, it's not 100%, but it's pretty close. And you're right, AI will help to raise that number even more. And mammograms are so low dose, don't need to worry about the radiation exposure.
Thank you. Good questions. Thank you, Dr. Pederson.